Good day everyone, I am Dr. Osama from Easy and Different Radiology. Today I'll talk about one from most important presentations for ER and radiology on call doctors. My presentation today is how can fat stranding be used as an incredible tool in diagnosis of acute abdomen. So let's start. The learning objective from this presentation: first, definition of fat stranding. Second, localizations of fat stranding in which abdominal quadrant or in the center. Third, how to confirm your diagnosis through scrutinizing suspected inflamed organ. Definition of fat stranding. Fat stranding is increased CT attenuation, which can be ill-defined, reticular, linear, or reticulonodular in some malignancy. Fat stranding is a non-specific sign in itself and can be seen in infection condition, inflammatory condition, malignant conditions, or traumatic condition. This diagram shows the normal fat from the fat stranding. Normal fat appearing as this barely visible line, few thin connective tissue, pencil thin, peritoneal fascia, homogeneous fat density. However, the fat stranding is ill-defined margins like these lines, slightly increased density, fat still seen amid increased connective tissue line. The peritoneal and or facial thickening appeared as well-defined, thick line and linear like this. However, the free fluids appearing well-defined, true fluid density in the CT, no fat interspersed, and can have meniscus like this. This is the main core for my presentations, which is the fat stranding. Fat stranding appearing like this, irregular, ill-defined line of high CT attenuations appearing surrounding the organ of inflammations, like this surrounding the kidney in acute pyelonephritis, or this surrounding a pancreas in acute pancreatitis, or this surrounding a gallbladder in the acute cholecystitis. Also here, there are fat stranding in the periappendicular regions for acute appendicitis or omental infarction. TB peritonitis appearing as omental thickening with fat stranding like this, also pleural effusion. Epiploic appendicitis appearing as fat stranding regions, and also pathology of acute diverticulitis can be detected by these fat stranding surrounding the diverticula here in the rectosigmoid region. Also fat stranding in the middle of the abdomen like this for the mesenteric panniculitis, or surrounding the terminal ileum in the cases of Crohn's disease. So the main issue from these presentations is the fat stranding and how can helping and can be used as an incredible tool for the diagnosis of acute abdomen. This is another diagram which localizing the area of abnormal fat, which representing as a fat stranding, if in the right upper quadrant or left upper quadrant, left lower quadrant or right lower quadrant or the center of the abdomen, to make your differential diagnosis according to the site and the localizations of the abnormal fat by CT. For example, if the right upper quadrant is the area of interest, so you should confirm your diagnosis through scrutinizing the gallbladder for diagnosis of acute cholecystitis or right kidney for pyelonephritis. If the fat stranding are detected as the left upper quadrant, so now you should scrutinize the pancreas and left kidney to diagnose acute pancreatitis or pyelonephritis respectively. If the fat stranding you detected it as the left lower quadrant, so now the most common diagnosis is acute diverticulitis and should scrutinize the colon and diverticula arising from it, or epiploic appendicitis. If the fat stranding is seen in the right lower quadrant, now acute appendicitis is the most likely diagnosis. You should scrutinize the appendix to confirm the diagnosis through other Features of the appendicitis like thick wall and appendicolis or like this. Crohn's disease, you should scrutinize also the terminal ileum to diagnose it or a mental infarction. However, if the fat stranding are detected at the center of the abdomen, now you should scrutinize the TB peritonitis or mesenteric panniculitis as a cause for this central abdominal fat stranding. So this diagram is depend on the site or localizations of the fat stranding to detect the differential diagnosis suitable for that. And now we're gonna go to talk about some scenarios through cases, real cases, daily cases done, and other cases to confirm this concept of the fat stranding according localization of it can detect the pathology and can detect the acute abdominal cause. Actually, this is very important during the on-call and ER situation. S1, scenario 1, this CT abdomen with intravenous contrast, coronal, reformat imaging, and axial imaging showing areas of ill-defined fats and high attenuations at the regions of the right upper quadrant. So the differential is between the gallbladder acute cholecystitis and acute pyelonephritis. You should scrutinize both organs. Here, the gallbladder showing a thick enhancing wall with multiple stones and disease fat stranding representing acute cholecystitis. There are also air within the gallbladder. So, right upper quadrant fat stranding representing diagnosis of acute cholecystitis in this case. Other scenario, this CT abdomen with intravenous contrast showing area of fat stranding which appear ill-defined and high attenuations in the center of the abdomen. However, the mesenteric vessels are appeared through the fat stranding region with no thrombosis within it. So now the localizations of fat stranding in the center of the abdomen, so mesenteric panniculitis or TB peritonitis can be both in differential diagnosis, and this was a case of mesenteric panniculitis. Another scenario, this CT abdomen done with oral contrast. As we see, the bowel is opacified and there are area of fat stranding appearing here at the left lower quadrant. Left lower quadrant fat stranding and surrounding the colon. Differential diagnosis is the epiploic appendicitis or acute diverticulitis because this lesion is adjacent to the colon and there are thick wall colon also. This fat stranding is representing acute diverticulitis. Allow me to show this case of the other scenario of fat stranding. As you see, this fat stranding here, by the definitions, it areas of linear, of abnormal high attenuations and irregular lines at the right lower quadrant. So by the localization of the site of the fat stranding, we shrinken the differential diagnosis between Crohn's disease, acute appendicitis, or mental infarction. If we scrutinize the appendix and found it as this case dilated and enhancing wall, so this was a case of acute appendicitis. However, in this scenario, we can detect the fat stranding in the regions of the left lower quadrant, as we see here, adjacent to the bowel, large bowel. So this is representing the appendages. There are no diverticular outpouching from the colon. So this differential diagnosis by the localizations of left lower lobe representing acute diverticulitis or epiploic appendicitis. As we see, this lesion is related to the appendages of the colon and there are central dot high attenuations or representing thrombosed vessel. Also linear high attenuations for this fatty region and also linear irregular lines of high attenuations representing fat stranding, and all these are the features of epiploic appendicitis. Another situation or scenario which representing this diffuse fat stranding in the anterior part of the abdomen and also related to the omentum. As we see by localizations of fat stranding in the center of the abdomen, the differential diagnosis is between TB peritonitis and mesenteric panniculitis. If we look definitely for this case, there are also high density fluids signal in the CT is noted here with meniscal signs representing ascites. So these features is highly suggestive of the TB peritonitis. Scenario 7. This fat stranding, which detected in the right lower quadrant, appeared as irregular lines of high attenuations in the CT, and there are also area of linear high attenuation surrounding the internal fatty lesion. These lesions in the right lower quadrant show the differentials between the acute appendicitis, Crohn's disease, or omental infarction. So you should scrutinize the appendix and the terminal ileum if they are normal. So you can consider the omental infarctions as a cause for this fat stranding in the right lower quadrant, because the right lower quadrant is the preferable site for the primary omental infarction. Omental infarction can be secondary due to surgery or trauma. At that time, it occurs at the site of trauma or surgery. And the main differential diagnosis for it is the epiploic appendicitis, which is most likely occurring in the left lower quadrant. And also, it is smaller in size, and the fatty lesions inside is slightly clearer than that fatty lesions, which is more than 5 centimeters usually. So this was a case of the right lower quadrant fat stranding lesion, and the diagnosis is omental infarction in this scenario. Another scenario with CT, unenhanced CT of the abdomen, coronary format imaging, we can see fat stranding here surrounding the left kidney, and there also irregular lines with high attenuations representing perinephric fat stranding. You should scrutinize the left kidney and the pancreas. If we look at this image, we can see dilatations of the left renal pelvis and the proximal part of the ureter. And if we scrutinize the ureter, we can find this high density stone at the proximal third of the left ureter. So this fat stranding surrounding the left kidney is represented obstructive uropathy. Another scenario for the fat stranding in the left upper quadrant, as we see in the coronal image here, there are fat stranding here. And this is the colon, and this is the jejunum, and this is the right kidney and liver. This is part of the stomach, and this is the body and tail of the pancreas. So this fat stranding is surrounding the pancreatic region, and also confirmed here from this axial imaging. There are also some effusions noted by its CT density of fluids and the meniscal sign and well defined. So fat stranding and effusions in the left sides with pancreas swollen and appeared as inflamed. So this was a case of acute pancreatitis. The scenario 10 is the fat stranding at the right lower quadrant regions, which appearing irregular and high attenuation. Right lower quadrant, appendicitis, Crohn's disease, and omental infarction. You should scrutinize the appendix. As we see here, there are dilatation of the appendix more than 7 millimeters. There are enhancing thick wall and periappendicular fat stranding. As we see in the magnifying image here also, there are dilatation of the appendix, and in this sagittal image, reformat imaging shows the appendix surrounded by fat stranding. So this was a case of the acute appendicitis. And last scenario, this fat stranding, which appearing in this coronary format image as the right lower quadrant. So the differentials is between appendicitis and Crohn's disease as well as omental infarction. You should scrutinize the terminal ileum and appendix. If the appendix is clear and normal, so now the terminal ileum appeared thick wall and surrounding by this fat stranding as a landmark for the inflammatory region, and also there are narrowing of the lumen of the terminal ileum. So these pictures can be confirmed by presence of other escape lesions to confirm diagnosis of Crohn's disease. Crohn's disease can cause pre-stenotic dilatation and luminal narrowing and also fistula formations with the surrounding structures as that with colon or with the urinary bladder and so on. Summary and conclusion. So now what's your plan, CT plan, when presented with acute abdomen? My plan is depend on 3 steps. First step, detection. Second, localization. Third, confirmation. Detect fat stranding, localize its site in the abdomen, then confirm your diagnosis through scrutinizing suspected inflamed organ. And this is the same diagram which shows the localization of fat stranding in the left upper quadrant. Acute pancreatitis and acute pyelonephritis can consider in differential diagnosis. If it is in right upper quadrant, acute cholecystitis and acute pyelonephritis can be considered. If the fat stranding in the left lower quadrant, acute diverticulitis and epiploic appendicitis are considered as the most common differential diagnosis. Acute appendicitis, Crohn's, and omental infarctions most likely occurs as the right lower quadrant as a cause for fat stranding. If the fat stranding in the center of the abdomen, TB peritonitis and mesenteric panniculitis can considered as a differential diagnosis. Don't forget to subscribe my channel now to receive any new presentation like this in the near future. Thank you very much for your watching and have a nice day.